The world's best physios don't just treat, they coach. Here at the Physio Coach podcast, we invite the best physios, coaches, and health experts to inspire you on your journey to becoming a physio coach. This podcast is sponsored by Better, provider of in-person physio and personal training services in central London. We help people feel better, then live better. We believe that better never ends. This podcast exists to inspire your journey to better.
So at the end of every episode, I ask the guest, what does better never ends mean to you? So at the start of this episode, I'm asking it to myself, or at least I'm going to answer it for you. So we're here on our first live episode. So we've done 60-ish. Brian, help me out here. Is there a number? 60-ish now overall. I'm sitting next to the man who I started them with, Andrew Goodall. Also my best friend, best man at my wedding. I was best man at his. So it feels really special to be sitting next to Andy, as I usually call him. But I did have to ask myself a couple of months ago or a few months ago, okay, we're pretty comfortable now with the podcast. We're recording them in a nice, cozy little space with me, the guest, and Brian normally in the background, checking the cameras are all running. But it was a bit safe. It was pretty comfortable for me. And the regular listeners will probably have heard me talk about me being an introvert. I hide it well on the whole, and pseudo extrovert, as I've been told. But the regular listeners will know that this is still intimidating for me, having people in front of me. There is a difference. The camera almost shields it. So I thought, what's going to take me out of my comfort zone so I can grow? Because I need to grow. I need to continue to push myself out of my comfort zone. And I was speaking to this man here, James, from Arthrosamid, a few months back. In fact, it was probably a bit longer than that. It was probably 6 months ago. Over a very good coffee. And I had this idea. I think I want to do a live podcast. Would Arthrosamid be interested in sponsoring it? So here we are, however many months later, and we made it happen. So I'm outside of my comfort zone for sure. Very pleased to see you all here. There's an exciting topic to talk about tonight. We are talking about knees. Arthrosamid would make sense that we talk about knees, and we'll talk about that product a little bit later. But we're really here to celebrate the journey that I've been on, and the journey myself and Andy have been on from the beginning, and to take it to the next level. So let's get started with the actual episode here. So Andy, I want you to get us going with some knee myths, some myths about knee injuries.
Okay, I was worried then. I did bring the best man speech, if you... Okay, myths. I think probably one that resonates with quite a lot of people is that a lot of stuff that's out there says that running is bad for your knees. I think that's probably the most important one to tackle. And there's been a fair bit of research that has refuted some of that, especially in the healthy knee, especially in the non-pathological, uninjured knee. I think we should be really positive about running. We know that tissues respond to load, and as such, running is just a type of load. And if you've done the right training and you've built up correctly, and you're lucky and resilient, you'll probably be all right with running. I think that's important. And obviously, we need to consider when we're talking about the pathological knee, maybe the big meniscus tears, the advanced arthritic change. But when somebody who's had big changes in their knee asks me that same question, I tend to revert to how important is it for you before I revert to whether they should or shouldn't. Yeah. And I think that's probably the first myth I'd like to bust.
Yeah, and I'd just like to add, for me, I'm normally suggesting that there's an increased time for recovery for a pathological knee. If there's been degenerative change, if there's been big structural injury, ACL deficient, whatever it might be, they normally just need more time to recover. So the average person, recreational runner, 3 times a week, pretty common. There's a good chance a pathological knee won't cope with 3 times a week, even if they're really diligent with rehab and really persistent. They may do, but I think for those that just want to get back to enjoying a bit of running, it's more realistic for them to be thinking about dialing back on the volume and the frequency.
Yeah, exactly. They might just enjoy it. Often they just say, do you know what? I just want to do part run. Yeah. And who am I to take part run away if it's not dangerous for them? I think we should probably facilitate that, as long as we've educated them that, like you say, it might take a bit longer. Maybe sometimes it might be a bit sore, but that might be safe. sore isn't or painful isn't always something to really worry about. It might be totally safe and appropriate in certain situations to accept that. So, I'm a big advocate of trying to help the person do the thing that drives them, the thing that gives them life. You know, you hear so many runners describe themselves as runners. You know, if you ask somebody, you know, Charlie, you know, what do you do? You're like, I'm a runner. So it's quite hard to give that up sometimes. And there should, and hopefully there is a way to keep that.
And if we look at the stats on OA, so the recreational runners tend to get knee and hip OA. It was a study done on knee and hip OA at about 3%. And then the sedentary person gets knee OA, is it 10%? I think.
Yeah, 10%. It's close to that. And the thing there is I think we can say that exercise is protective in many different ways for many of our systems. And living a more active lifestyle is a positive, most likely. And those that are engaged in activity often are engaged in other aspects of life which are healthy for them. You know, I know what I'm like. If I'm not training, my diet might slip, as an example. I might satisfy that itch where I normally do park run by having another beer. You know, and I'm not saying that's wrong. It's just that, you know, we have these vices, and running might be the vice or the outlet that we pick to manage ourselves, mental and physical.
Yeah, I think I know that I speak for many people here that if I'm exercising, everything else kind of comes into place. It all layers on top of each other. I've heard James Clear talk about it as his keystone habit. You know, what's the keystone habit that everything else falls on top of? So for me, exercise is the one.
Yeah, we saw that in COVID, right? We saw so many people COVID was a real struggle when we saw so many people pick up running. Some maybe went a bit far or struggled with injuries as a result of that, or lots of different reasons. But COVID, we found this like solace. A lot of us found solace in exercise, whatever it was, cycling, running, whatever it was. But I think the other thing is I try to demystify that 5K is a short run. Like, you can run 2K. If you can run 2K and that feels okay, just run 2K. You know, it's like, it seems like, oh, I did a short run, it's 5K. It's like, it doesn't have to be 5K. It could just be 2K. Yeah. And if you enjoyed that, great.
Myth number 2.
I probably have to go towards ACL. Like, that's just my bag. I would say not all ACLs need surgery is an important one. I think physios can take real life from the fact that ACL seems to be much more drifting towards a physiotherapy-driven approach. I mean, it always has been, but you know, it's less about the surgical, and the physio is part of it. And there's a big cohort that are going to be appropriate for non-surgical management, whether that be bracing protocols or just conservative management without surgery as such, without the brace and such. So I think, you know, you don't have to have an ACL reconstruction if you have a stable, functioning knee, you know, that isn't giving way on you in normal tasks, and you've done the training and it's behaving well, it's not swelling, and you can do the things you want to do, you're probably going to be all right.
What about someone's on the fence? Because the physio audience out there are going to be like, but my patient's still asking me, you know, what do I do this way or that way? The one that's on the fence, what kind of questions are you asking to help them decide?
I like to ask them what they do and what's important to them now and potentially in the future. You know, for me, for instance, right now, I don't play team sport. So if I injured my knee and it was totally stable, I had an ACL injury, sorry, and it was stable, I'd done the training, it was fine, I'd be fine. But if in 5 years' time I'm expecting to go back to 11-a-side football, I'm not saying that won't be fine, but there might be a consideration to be had there, especially if it's at a reasonable level. Now, people that don't have surgery get back to sports, pivoting sports, cutting sports all the time. That definitely happens. But there might be a different discussion to be had than the person who is maybe a little bit older, like me. You know, I'm nearly 40. I don't play change of direction sports. I'm unlikely to play change of direction sports. I'm quite happy cycling and running. If you said to me, look, you can't go skiing, I'm not saying you can't, but if that was the discussion, I would be like, okay, that's fine, I'll modify. I think the ones that are sitting on the fence, normally I would say, have a couple of discussions with people I respect. Chap coming today, Kash, I'd say, look, he's very conservative. He's conservative on his approach for who he will push surgery on. And as such, I think you've got to be able to trust to refer on for an important discussion that might be useful hearing from a number of different voices rather than just my own. Because I do think the surgeon still carries more weight as a patient. Mm-hmm. If you see a surgeon that suggests that you're going to need surgery to do the things you want to do, it's quite a difficult turnaround as a physio. I still think that's true.
And how do you sense it if a multi-ligament meniscus involved? Is that a more clear-cut decision?
Yeah, I'd say so. I think you need to understand the opportunity for further harm. And in my mind, it's like ACL plus, as I call it when we teach it. The more things wrong, the more chances you have that knee might not cope. That doesn't mean it won't or can't. I'm sure there's people out there who've got, whacking great injuries that have managed totally conservatively. But the percentage of those that are going to cope that have had a very significant, let's say an MCL rupture, an ACL rupture, whacking great lateral meniscal tear, it's going to be much lower than the isolated ACL, which is, if you're going to injure your ACL, you kind of just want to injure that and leave everything else alone, ideally. But we know that's rare.
Yeah, my sense is they start playing with risk in the wrong way because they don't know the future well enough, where the data is suggesting that unstable knee is more likely to get OA.
Exactly.
And even though the data says that, we can't guarantee it, but I would still then think, I don't want to play with that risk.
Yeah, because like I was saying before, you have to think about the future you as well as the current you, right? And we know that progressive meniscal damage is going to be a problem. Recurrent meniscal injuries are going to accelerate the degenerative change in your knee. And quite frankly, the reason we're trying to stabilise your knee for the ACL is to protect your meniscus and your cartilage. We know you can cope. If the meniscus wasn't injured subsequent to an ACL being injured, we'd probably just leave it alone if that wasn't the problem. But given that when you tear that, you get instability that makes the other structure susceptible, that's the point of doing that reconstruction. And if you've got MCL, which stabilises you into valgus, medial meniscus, which gives you rotatory stability into that direction, and you've ruptured your ACL, the chance of you having another valgus event that's going to cause instability and probably damage your cartilage as well as your meniscus at that point has gone up.
Yeah.
And we have to weigh that up, I think.
You then have less options.
You have less options, exactly.
Myth number 3?
People that know me from any platform will know that I bang on about the knee extension machine. So I would say open kinetic chain, knee extension exercises like the leg extension machine is not bad for your knee. It is not causing your arthritis in your kneecap. It is not dangerous for your graft.
Could we say quite the opposite?
We could say quite the opposite. There has been some studies fairly recently in an ACL cohort where they picked a very selective criteria, pain that was very low, quads that were highly active, in people that were coping basically pretty well at the start, that started knee extensions very early, and when assessed at like 12 weeks down the line with a machine that tests for laxity, specific laxity, they had less laxity than those that did not use the knee extension machine. Now, that's not to say that you should be on the leg extension machine at 5 RM compared to your other side at 3 weeks and just banging away. Like, that's just not sensible. But like we don't tell them to run at 6 weeks, it's just another exercise modality. We might not tell them to perform heavy 5 RM knee extensions at 3 weeks, 4 weeks, 5 weeks. It's just graded exposure to an exercise. It's the same as any exercise. And that's ACL, but you can lean that into PFP and all those guys as well. A lot of the time with patellofemoral pain problems, yes, they have knee pain, but they also have quad weakness. And if you can find an entry point for an exercise that specifically loads one of the problem muscles that doesn't aggravate their symptoms, then it's worthwhile. And I always just talk about entry point. We're trying to find an entry point. It doesn't have to be the leg extension machine, it could be any exercise. We're trying to find your entry point for this particular movement, for whatever reason we've decided. That might be a hold, it might be a modified range, it might be in a slightly different position. It might be a different angle as such, but I don't think we should demonise any exercise. And I get quite frustrated by the fact that the leg extension machine seems to be a point of contention about whether it's a good exercise or not. You know, bodybuilders have the biggest legs out there, but ask a bodybuilder if they use the leg extension machine. Like, they have, other than me, they probably have the best quads out there. So we need to consider,
Charlie's pretty decent.
Yeah, it's mostly padding. But, you know, we need to lean on the people that do it best.
Yeah.
I always say, like, stand on the shoulders of, like, the giants, you know. You don't have to rewrite all the rules. Follow the guys that do it best already. You know, they build muscle better than us. What do? They eat a lot. They use lots of different isolation and compound movements, and they train frequently. That sounds like physio to me.
I've always said that good physio rehab looks just like a gym program, but specific to the injury, modified for the injury in the person.
Yeah. You know, I regularly say to people that physio universities won't like this, but I do more sports science now than I do physio.
Yeah, same.
And I have an MSc in physio and a BSc in sports science.
Yeah.
And I use more of the stuff I learned as a bachelor than I do as my master's degree, which is a bit more broad.
That's funny, I've never heard you say that. And yet I've been saying that to my patients recently quite often, that I really lean on that sports science learning a lot now, probably more so than I did earlier in my career. And actually on that, so we both did the same degree. That's where we met, university. We did the same masters in physio. We had a fairly similar start to our physio journeys. I've ended up being more of a generalist physio, and you're a specialist within sports knee. You're the sports knee physio, right? So you've claimed it, you've grabbed it. What was it about your journey, do you think, that led you to being a sports knee specialist?
Yeah, I use the term specialist carefully. I'm happy for you to say that, but you know, I would say I have a special interest in the injuries. It's probably where I feel comfortable. It evolved. Quite frankly, my first physiotherapy placement, and hopefully this resonates with some, I hated it. I had MSK as my first placement. My educator I didn't vibe with, I didn't get on with that well, and I struggled. And I walked out of that first placement and thought, that's not for me. And as I was going through, I really enjoyed neuro outpatients, and I honestly thought that's probably where I was going to end up. I really got quite a lot from that. I really enjoyed the journeys with people that, you know, recovering from a stroke or Parkinson's, and trying to help these people with my first degree skills in people that just got quite basic physio. Is like, okay, well, can we progress this exercise? Can we get you stronger rather than just focus on can we get you moving? It's like using some principles of training. And then I got a Band 5 job, did the whole rotations, and I landed in a team that was amazing. I landed in a really good team at Chelsea and Westminster, and there were some people in there that inspired me to try and get better. And I think I got energy back from that. I just realised that, like, what I really enjoyed in the neuro outpatients was that I didn't have this person that just kind of was just constantly berating me in a way. It was the same environment, just with a different population. And what sort of swung me that way is, as much as the neurological stuff is, of course, athletic, I like sport, and I was going to see less of the sporting type injury. And so I wanted to apply that to a more sporting type of application that I saw at the time, and that's where it drifted to MSK. Very quickly, I ended up being the static Band 5, so I took over. I got given the ACL class at the time. I liked it. I thought it was crap, if I'm honest. It was really bad. You know, the hardest exercise was a walking lunge, body weight, or a step up onto an old school wooden bench with two kilo weights with a wobble board underneath their foot. And I just was like, this doesn't make sense to me. All of our patients were getting discharged at, you know, points at which they were still pretty bad. So I tried to evolve some change there, but I was, you know, pretty young into my career, to be fair. Wasn't really my place to change it completely, but once I became static Band 6, I got a bit more control. I started to modify it, made it harder. We still had limited kit, but I enjoyed it. And then a friend of ours, Mehmet, put me in touch with a rugby club. I went and worked at the rugby club. A few people injured there. ACLs there, loved that. And it just sort of rolled. As I think as careers do sometimes, it kind of, you're just kind of stumbling sometimes, but you're just finding the bits you like, and then you kind of stumble over there a bit, and you're like, that wasn't great, and I like that, and you just, in the end, it kind of shapes into where you end up, and now I'm 15 years in, and I see 80% knees, and probably 80% of that is ACLs.
Yeah, that's an interesting point about, it almost sounds chaotic.
It was.
The journey through that. And if I think back to my development and my time, like that's exactly what I felt. Like just chaos and try a bit of that, 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 and actually not sure about that. And then you find the thing. And it probably was only into my 30s where I really felt like I knew myself as a physio, actually. I was still figuring things out. Same as you, I thought I'd be a sports physio and tried it, but just wasn't for me.
Yeah.
Too much watching training, too much traveling on buses.
Yeah, and I think you've got to find, sometimes you enjoy the thing where you feel like you've got the most impact. And it just so happened that I work at Pure Sports Medicine now. I've been there, nearly 10 years, which is mad. And, I was working with corporate people in a really lovely gym. And again, you start to see lots of the same thing. You work with consultants, they send you more, you get a good result, you start to build a relationship, and I think physios naturally, unlike yourself, on the majority, you sort of gradually end up doing this. And it might not be mine is, I would say, quite niched down, but it might just be that you treat lower limb. It might not be quite so niched. Mine is just honed in a bit more.
Exactly. And let's hone right in on that knee. Right. So what happens when a knee gets injured? Tell us the basics around why knees get injured.
I think let's do the why. Why is a difficult thing to understand, and it depends on the type of injury. There are a number of different ways you're going to injure your knee. There is the moment, as I call it, the change of direction, the stop, the landing type of injury, and that there seems to be a number of pathologies that fall into that. And then there is the kind of like training error type of situation, like my left knee when I ended up getting IT band, and we probably talk about that later. And then there's the kind of progressively evolving, degenerative, changing type of knee, which has normally come from some of this and become this over here. It's normally maybe a moment injury started the journey towards this more degenerative type of knee. But I would still say, I see a lot of ACLs, so most of mine are moments, but the biggest volume of knee injuries is in probably the training error block. Yeah. The PFPs, the patellar tendons, the IT bands. 50% of running injuries are knee injuries. So there's a lot of runners. So you're going to get a lot of those too. What happens is, it depends on the problem we're talking about. It hurts. The moment type of injury tends to come with swelling and mechanical symptoms, typically. Not always, it depends on the severity, but typically mechanical symptoms like locking, instability, like I said, significant swelling, normally a fair amount of pain, sometimes an extreme amount of pain. Difficulty weight bearing might be part of that. Altered motion could be part of that. Squatting, lunging, going on stairs could be particularly difficult. That's your moment injury. Your training load one is the niggle initially, normally. Typically, we know that the training error injury might not evolve for 3 or 6 weeks after the initial training error. So sometimes they'll say, I haven't done anything different. And then you go back a bit and they're like, oh, well, I wasn't running and now I'm running 25K a week, but I've been doing that for 6 weeks. Okay, but there was a bit when you wasn't running and then you did a lot of running. That's an extreme example, but as an example still. And then it became a niggle and I tried to run through it. It wasn't too bad. I could do 5K and then I rested it and it got better. And then I tried to do another 5K, but it was 3K that time. It's that sort of thing. So there's a bit of a distinction between the two.
Where would you put the biomechanical type injuries, the one where you're kind of looking above and below the knee as the potential cause of overload?
I think you're always doing that with any of them. You can do that. I think your moment injury, you still have to do that too. I don't think you can kind of look at pathology without looking at the above and below and the movement pattern and the way they move anyway. As I've got more experience, whether this be right or wrong, I would say I try not to necessarily just blame anything in general, like, because you see the person with the weak glutes or the tight hip flexor and the weak calf or the flat foot, and yeah, cool, but there's probably some other stuff too. It's probably their mechanics plus training error perhaps, plus a new action, a new exercise as an example. So I think mechanics is part of why you potentially get a problem. Mm-hmm. I'm an example of this. I have a fairly bowed tibia, a bit more on my left side, and I run naturally, because of that, quite narrow. Wear patterns don't give you much, but if we just said, I typically wear out the lateral part of my shoe, mm-hmm. and I almost every run nearly roll my left ankle. It doesn't happen, but it happens, but it doesn't happen. It doesn't actually roll. And as such, that gives me the opportunity of some injuries that might occur in and around this outside portion where there is going to naturally be some more stress.
Of which we can start to look at that ITB injury that you had.
Yeah. So I would say mechanics is normally part of it. Yeah. We can't ignore it. We should respect it. But also you can, but you're not going to change my left tibia.
Should probably leave it alone. Yeah.
So yes, the mechanics are important, but that I'm not going to change that always. So there would be some other stuff you're going to look at too.
So you were saying that biomechanics plus. So in your situation, let's talk about the ITB for the sake of exploration here. What was the plus in your situation? Because you had that for 18 months. Longer?
Yeah. But I really struggled to get it better, which is shameful, I suppose, but it's true. Do as I say, not as I do. So there's a few pluses. So I have Crohn's disease, which makes me a bit more susceptible to sort of inflammatory problems, specifically around sort of attachments. It also means I can't take anti-inflammatories. So I would argue that also gives me a slight more chance if I get my training wrong, and also it takes something off the table to help me manage it initially, which is a bit of a problem in this sort of problem. So that's A plus. The other one is it was back end of COVID, I'm going to say 21, I think, and we'd just been training to cycle from Essex to Leeds, which for people that don't cycle is really far.
2 days, by the way.
Over 2 days, yeah. My bum still hasn't recovered. And we were just putting so much training into that because I wasn't a cyclist. And as anybody knows who'd booked races around that time, the races just kept moving. It was like, the half marathon, it's going to be next week. It's cancelled. It's going to be in 6 months' time because of COVID, basically. So I just looked at it and thought, let's just cancel it. It's not going to happen. It was literally 2 weeks after we cycled to Leeds, and it didn't move. And classic, I've signed up for this. I've barely trained for it. I'll be fine. I did some runs beforehand. I think I went from 5K, 10K, 12K, whatever it was, 15K in 2 or 3 weeks after being quite fatigued. I was fine on the day. Well, I was slow, but I managed it. Didn't have any pain the next day, didn't have pain for a few days. And then I went for another run. Bit of a niggle. I'm probably a bit tired, so I just stopped. 2 or 3 days later, went for another run, had to stop. I can't run on this leg. There's something going on. And for anybody who's had IT band pain, acute IT band pain, that next day walking down the stairs was like a knife in the side of my leg. Honestly, it was like eye-watering. And yeah, that was the start of it. And classically, you do the try and rest it, do the training to get it better, but you think it's not going to last too long, and then you go back a bit too soon, you irritate it, you run a bit too long, and you get into the cycle that patients do. At the end of the day, I was a patient. Sometimes you don't appreciate your own injury as you should. You can't objectively look at yourself as an injured person sometimes.
Well, you'll know well, my back injury, I came to you as my physio. My ankle injury, I went to see Rebecca Christensen for that, because For big injuries, you just can't objectively think and rationally think about managing your own problem. So it's better to get the emotions out of the situation and go to someone that can just think rationally about the problem.
Yeah. And, I did the training. I did a lot of training to get it better, but I did what most patients do. I kind of got it feeling better, got pretty strong again, dealt with the biomechanical weaknesses type like glute training, calf training, did that. Probably didn't do enough for the plyometric build-up because it was going okay. And obviously I'm a physio, I'm pretty robust, I'll be fine. Go and run again. Goes fine for 4, 5, 6 runs. Oh, it's back again. And as anyone that's lived this experience knows, like once you annoy it again, it's not just a couple of days and then you're back where you are. It's like now it's inflamed again, you've got to calm it down again. Then you have to go back, you have to take those pliers out a bit. And it's just this ebb and flow of lots of injuries that I'm sure people have had. It's mentally draining as well as physically draining. And when you're managing people with knee injuries and dealing with your own knee injury, I found that quite tough too. Because it's like, yeah, I get it. Also, I'm a bit annoyed because I can't go for a run and I want to go for a run. And you almost live it with them, in a way, especially when you see some of the same problems. So, yeah, it was incredibly frustrating. It's better now. I ran the marathon last year, which was great. It hasn't caused me a problem since, but it's still something that reminds me that I'm now 38 and I need to be sensible about how I train. Because probably when I was 20, I reckon I'd have probably been fine. That's maybe me being me, but you just bounce a bit quicker, don't you? Things don't affect you quite as much.
Yeah, and I think this is why we end up being really good physios when we've had the problem ourselves. I'm sure everyone in the room that's had an injury, they feel more capable of handling that injury if they've had it. The empathy side of it, the knowledge, the failures, the errors that you make along the way. I think it's
spot it earlier as well.
Yeah.
I'd say once you've had an injury, it doesn't take long into their story before you're living that story with them. They're like, oh, I went for this, and they start going, oh, I walked down the stairs, and it was like, and you're like, yeah, the diagnosis straight away. So that helps.
If we're talking now more about a moment injury, it doesn't have to be an ACL, but you probably prefer it to be perhaps, but day 0 of an ACL injury, and then take us through that first week of what a physio will be looking out for, what advice they should be giving at that really early stage after a moment injury.
I think the first things first is you need to capture what that moment was mentally. You need to listen, because they're going to tell you that this is the same for any, I remember being told at physio school, it's like, listen, take your history, make sure you take out how it happened, when it happened, what their aggravating factors are, what their easing factors are, what the mechanical symptoms are. And when I was first there, I was literally just trying to listen and fill out the boxes. And that's all I could do is just fill out these boxes and make sure I asked all the questions. Now I listen. And I often don't type. We don't have AI, like the Heidi or whatever it is.
Yeah.
So I just, especially when they come in and like, oh, I injured it playing football, you're like, okay, I'm going to type that later. Tell me what happened, specifically, if you remember. What was you doing? Where was you? Where was you on the pitch? Was anyone near you? Was it a contact injury? Was you attacking? Was you defending? Did you turn? Did you land? And often they've told you all that already, but if they're not quite sure, you can dig a little bit. Ask them if it's on video. We video everything nowadays. The amount of patients have come in and said, yeah, my mate videoed that, have a look at it. Yeah. So specifically, you want to pick up what specifically happened at the moment, at that time. Was you able to carry on? Was you able to weight bear? That could also be quite indicative about whether this is, an articular type of injury, like a meniscus problem or a cartilage problem, for instance. How did your knee behave immediately afterwards? Did it swell quickly? Within 24 hours, was it very swollen? Was it swollen specifically to an area or more, grossly around the knee? Obviously, is there any visible deformity? Does it feel unstable? Did it feel unstable at the time? There's asking people about did you hear a pop or a snap or a crack or whatever? And some do, but there's been a fairly recent study that said that's not that sensitive for picking up an ACL. You can't rely on, they didn't hear or feel a snap or a pop. And if they didn't, well, it's not you can't rely on that. It's that cluster of things they're going to describe, those parts within that moment that happens. And often the behaviour within the 24 hours or the 48 hours after that injury is quite revealing about the severity of that injury.
What would you expect to see on a more severe injury?
You're going to get gross effusion. You're going to get restricted range, and quite often, well, they're going to have to stop. They won't carry on. Like I say, it'll be grossly effused. Typically, it might feel unstable or very weak, might be the way they describe it, rather than unstable. So a lot of patients don't say, my knee feels unstable, feels like it's going to give way, feels different, doesn't feel connected, feels weak, feels like I might fall down. They often won't, again, they won't say, we ask about locking. No, it doesn't feel locked. Okay, well, can you straighten it? And when you do, is it possible to straighten it even though it hurts? No, it feels like it's stuck. And I'll often say, does it feel like there's something in your knee? Does it feel like there's something in the way? Rather than is it pain that's stopping you with your range, as an example. And then you typically, with a bigger injury, you're going to notice difficulty in range in both directions. It's going to affect flexion and extension. That's very typical, just because of the amount of swelling. Those are kind of your initial big ones, really. And obviously the weight bearing. How do they feel when they put weight on it?
Once you're starting to get an idea of diagnosis, what's the advice you're going to give to someone? Because to some degree, a lot of the acute injuries will be managed quite similarly, I would expect. But what's the advice that you'd give to someone once you've got a sense of the diagnosis?
Yeah, I talk to people about the fact that this is an acute knee injury. You need to treat it like an acute injury. We don't need to worry about whether you're doing knee extensions today. We need to get your swelling down, your pain down, and avoid any more chance of more injury in the next few days. So swelling and pain are your biggest blockers for muscular function in the early phases post-injury. If you manage those poorly, then you're going to rapidly accelerate how much muscle loss you get. The more we lose, the more we have to gain, right? As Warren Buffett said, the best way to make money is not lose money. That's literally what I say to my patients. It's like, get it up, get swelling down, get the pain down, make sure you don't re-injure it, use support. Crutches are, there for a reason. And then as it feels more comfortable, less painful, we can start to activate or turn on or use your muscles, whichever word helps them understand what you're trying to do. And try to educate them so that they feel comfortable in what the process is for the next few weeks. Because it is terrifying to think that you have an injury that's significant that you're going to need surgery for, especially if you've never had surgery before, or maybe even if you have had significant surgery. So they're looking for support as much as they're looking for advice around what to do. They're looking for, not looking for empathy, but they probably need some empathy, or they need care, right? They need you to feel like you understand the gravity of their situation. That's just as important as the exercise you're going to prescribe. When I see a really acute injury, and to be honest, they mostly go to the consultants before they come to me, just because of the way London really works and the way the referral system works, but I do see them sometimes. You're trying to help them manage their knee whilst they're going to get a scan that's going to come up. I'm going to talk to them about what scan they might expect. Why we're sending them for that. Who I'm going to send them to. Why I'm going to send them to that person. And then also I'm going to talk to them about the fact that, irrelevant of what we find, we're going to get this knee injury better. And hope is just as important as the empathy bit. If when you're injured you still believe you're going to get better, I think that is incredibly powerful.
I'd say that's a universal truth for us physios to be ensuring we give. That person needs to leave that room feeling hopeful.
And we know the research says if people are positive and have a hopeful thought about their rehab, they're more likely to get better.
Yeah, we can't underestimate the placebo effect. I mean, that's essentially what it's working on, right? The brain is then just primed for recovery. So, I mean, that's why they measure medication against placebo, because it is a treatment in its own right. Yeah. And I always say to them as well,
we're not going to win the race today. We just need to get you on a path to recovery today. It's going to evolve, not every time you see me, but it's going to evolve as we go, and we'll react to what happens. Today, we're making that first step forwards. Today is your journey, your beginning of your journey to get better, rather than the doom and gloom. It's like, today is the first day you get better. You came here for a reason and we're going to get you better. You might need a team and it might take a while, but today's the first step.
Speaking of teams, Mr. Kash Akhtar has just arrived. So I mean, that's pretty much perfect actually. We're just talking about the injured knee. So come up and join us on stage, Kash.
Sorry I'm late.
So Kash is late because he's been in surgery, treating a VVIP is how you describe it.
Yeah.
I guess that's kind of all we're allowed to know. But
yeah, no, apologies for being late. Great to see so many faces here. Hey, Dan.
But it's quite cliche, isn't it, that you couldn't turn up for the knee injuries talk because you are surgically treating a knee injury. So.
Absolutely. That's the day job. Keeps me honest.
Yeah.
How's it going?
So we're good. So we're halfway through. We're talking about what happens day 0 from knee injury. So actually, it's a great time to bring you into here. So Kash Akhtar, knee surgeon, for the listeners. He has been on a podcast of ours before. There's a great episode a year or so ago. And we are speaking more specifically to physios today, so we can go into a bit more detail about this. A patient has come into your room. They've been sent by your good friend, Andrew Goodall, who's packaged them up.
He's no friend of mine.
There's no way I'm sending them to him anyway.
They're feeling hopeful. They're feeling hopeful. That's what
Yeah.
we've got from that. They're feeling good about it. They've come to see you. They haven't got a clear diagnosis, but there's a moment injury that's happened. What's the kind of process that you're going to go through in that first session with your patient?
Sure. So we do see a lot of patients actually off the bat who come to me before they've seen a physio. And it's actually quite a routine thing for me to do. So we'll always take a history from them. Without being boring, that is the beginning of the consultation. And invariably, given that it's all I do, I just do knees and I see sports knee injuries, 95% of the time I know the diagnosis pretty much from the history, gives you a lot of it. And then if I can examine them, that gives you almost the whole thing. And the MRI often is just to let them know that I was right and to make them feel good about it. Occasionally there are times when you're not quite sure exactly what it is and it gives you a little bit more information. In the acute setting, when there's an acute injury that's happened the last day or two, then it can be really quite difficult to examine that knee. Even in my hands, I probably see comfortably 10 ACL ruptures a week. And I probably do 5 ACL reconstructions a week. But even in my hands, I find that if it's an acute injury in the first couple of weeks, it's really quite hard clinically to examine them and give them a clear answer as to what it is. Normally they'll say, I put my foot down, I turned, there was no one near me, I heard a pop, my knee gave way. You've got a really strong idea as to what that is. It swelled up straight away, I can continue. They've probably torn their ACL, maybe MCL, maybe a bit of meniscus. But so you can't always examine them in the first instance. Usually I can, because I don't tend to see them right at the beginning at day 0. The first thing for me is always just to get that swelling down. It is just to elevate them, to ice them. Often I will aspirate the knee. It is unbelievable how much benefit there is by taking that blood. And it's not really swollen. If you've injured your ACL or any major structure, your knee's full of blood. Getting that blood is really irritating. It's a chemical irritant. Just taking it out of the knee can give huge benefit and relief to them. And then, I will make sure there's no collateral ligament injury or something as significant that you can pick up. You can pick those up acutely. A posterolateral corner injury you can pick up pretty well acutely. And then I'll get them imaged. And I'm very fortunate being at Cleveland that we can get them MRI'd, pretty much straight away. And then that MRI will be reported within a couple of hours and I'll know the same day pretty much within certainly 12, 24 hours what the diagnosis is.
We've already covered at the start of the episode that one of the myths is that all ACL injuries need surgery. So we know that some will go down a non-surgical route. And at this point, they're going to then bounce back into Andrew's diary and they start their prehab journey. And that prehab journey can result in rehab and no surgery, or it could result in surgery. I guess at this point, some patients won't know necessarily whether they need it or not. So at this point, Andy, what are you then going to be doing as a physio or advising your patient from this point?
Yeah, I mean, we've shared a number of these where very often Kash will phone me and say, look, they've got their ACL injury, they're actually doing pretty well, they're recovering well, the activities they're looking to get back to might not mean that they need an ACL reconstruction. We're going to give it a trial of conservative management and then I'll see them again in 6 weeks or so and we'll have a discussion and see where we're at. That's not an uncommon conversation that we have. In that process, I say to them that I actually try to set some almost like goals for us to achieve in this initial time period. there's very good evidence, if we're leaning on the ACL for a second, to say that if you get 80% of your quadricep function back before you have surgery, if you have surgery, that you're going to get a better outcome at 2 years. So I say to them, look, our focus is to get you as good as we possibly can, whilst respecting the acute bit, so swelling down, pain down, get them walking normally and such, as good as you possibly can. And there is no block to how far we will take that. If you can jump or hop at the appropriate moment, we'll do it. Or run, yep. And, it's very often we've had discussions where it's like, actually, just carry on. They're doing great. Just keep going. And we'll see again in another 3 months or 6 months if they change their mind. And so I just say to them, look, initially we're going to focus on calming your knee down. Then we want to get your muscles functioning well. That could be, call that strength if you like, but also size. We won't just compare you to your other side. We're going to compare you to age-related normals. So people that are uninjured, that perform the sport that you do, that are as old as you, and normally and obviously the same gender. And the reason for that is then I can say, you're not just good versus your side that's been deconditioning whilst you're injured. You're good versus people that are healthy, well, and playing the sport that you play. I won't give them all the kind of, you need to get this amount of Newton meter, per kilo and such. At the start, some are interested in that, but it's much more about setting the journey that, we're going to compare you to values which are going to tell us how good you are. And prehab is just, rehab started before surgery. It's the same journey. I almost say to them, if you do prehab, when he does his surgery, when you come back to me, if you recorded that first session when you came, it's going to sound like that, apart from there's going to be some wounds, and we're going to respect some of that initial healing, but it's kind of going to sound the same. Get your swelling down, get your pain down, get your quads going again, get your knee moving within painful restrictions, and then we'll gradually progress it. It's the same journey, really. I think sometimes prehab is almost labelled as it's just the bit before surgery, but you drop the P if it does really well.
Yeah, and you keep running. I would say that there are very few occasions that I would want to operate an acutely on ACL. I don't think other than if I'm operating a professional footballer, where there are some time pressures from the club or the agent or the player, I will not operate on an ACL before 2 or 3 months post-injury. I don't think I've ever operated on one before 2 months, unless they've had a meniscus root tear or a bucket handle tear or an osteochondral fragment that I can fix back, a piece of cartilage and bone that's come off I can put back. I would not operate at the beginning. I say to everyone, go and have 2 or 3 months of prehab and then come back and see me. I don't want to make a decision about surgery prior to that. The other thing I'd say to people is that I always say to people, you end up in, there's 3 broad groups of people after an ACL injury. There's one group who'll do the physio, do the rehab, and get back to most things that they want to do. That's actually a really small group, if I'm honest with you, unless they modify their activities and they give things up. But that's a group. The other group is a group whose knee is so unstable, the knee gives way in the street, stepping off a curb, going down steps. Okay, you've got to have your ACL reconstructed. And in my experience, 90% of people probably fall into the middle group, which is they will do their rehab, they'll get to the point where they're walking normally, they can run in a straight line, they can do straight line activities. I go, then you've got a decision. Either then you do a pivoting sport and your knee gives way and you have an ACL reconstruction, or you decide, I don't care, I want to have an ACL reconstruction because I want to do pivoting sports, that limitation, and then we'll reconstruct your ACL. And I'd say most people fall into that category. And at that point, I say, look, the stronger you are going into surgery, the better you will recover afterwards. And categorically, I've never operated someone who's not done significantly better. Those who've done really good prehab will fly through their recovery. And I say that's the difference. You either put the work in before and you fly through it afterwards, or you put the work in afterwards and you have a pretty shitty time for 6 months after surgery.
Yeah, well, Andy said it earlier, the ones who don't lose it are the easiest to gain it on the other side. So that's what prehab is about. Yeah, the term I use is good going in, good coming out. I think we're all saying the same thing here. I just want to ask you about a specific part though, because you said that some will have an instability episode, pivot shift, and then they'll decide to have it. Is there an additional risk to that person having that extra pivot shift injury?
There is.
Having not decided to have the ACL originally?
There definitely is a risk of that. And the worry is that they could then sustain a significant meniscus or cartilage injury they didn't have. Yeah. Honestly, given the amount of ACLs and injuries I see, it's very rare. If you're talking about how often do I see a catastrophic injury that came afterwards, probably once every year, every other year. And so it's not that common at all.
So it's a pretty safe thing to advise them to say, give prehab a go, see how you get on.
Yeah.
You may cope really well.
But what I do is I say, do it in a controlled environment with your physiotherapist. Go out with Andy, go out with the guys, go through in a stepwise manner, a controlled environment. And when it's time to introduce pivoting, don't just go and play five-a-side. Do it in the gym in a controlled environment where you're thinking about it, there's no distraction. And if you can handle that, as you say, whether you can drop the P and prehab comes rehab, I'm very much, you go and that's your first milestone. You meet that milestone, go to the next milestone. Unless you're desperate or adamant you want surgery, and quite a lot of people just want it. There's a mindset for patients, it's torn, so it should be fixed. But I say, if you don't do that, you hit that milestone to the next milestone, just keep going. I put an Instagram post out yesterday from a bunch of patients I didn't operate on who have had ACL tears, who've done remarkably well. And if you can achieve the things you want to do and your knee is not feeling unstable, it's not giving way on you, have at it.
Yeah. There's a cohort of people as well that we have to work out who's willing to do the work. I think that's a really important thing, because if you have an ACL reconstruction by one of the best in the business and you don't work hard, you'll be worse. Because then you've got, the weakness and the inhibition and the just general deconditioning effect of having a surgery and then not getting back to normal.
And the fact that you've had a surgery, I think you can never underestimate the impact of surgery on a person.
Confidence, all of those things. And so I can categorically say, and we have shared some of these too, where sometimes there's a point where you go to somebody, look, you're not doing enough. You've had good surgery with a great surgeon. You've got a half-decent rehab program, I'd hope. But this is a sports surgery for people that want to play sport, that need the dedication to their rehab as if they were going to go back to high-level sport. And if you can't give it that, if you can't respect that, this is a really difficult injury to recover from.
Do you believe too many people have ACL reconstructions?
I think that is a difficult question to answer. I would say that people sometimes go into it assuming that if you have a reconstruction, you'll be fine. And Kash will know, we often have this discussion. We'll say, he will almost say to me, look, I've primed this person that they need to come to you and they need to work really hard, and I'm going to review them in 6 weeks. And sometimes we'll even say, I threaten them with surgery. We've said that before.
Yeah.
I threaten them with surgery. If they don't do the work, they're going to have surgery. And it's, obviously that's a somewhat tongue-in-cheek, but I've said this to people, I can't go to the gym for you. I can't do that I can give you the best program in the world. I can send you to SSE coaches like James sitting here, who I'm comfortable, knows the whole journey. But he can't go and do the pivoting when it's raining on a Saturday that you need to do if you want to play football. And, there's a reason why elite athletes get better. The same person did the surgery. They still get pretty much the same sort of rehab programs, hopefully, if they've got a good physio or a good SSE coach.
I've literally had that conversation. I've operated on a couple of ACLs today. One of them's a billionaire. And I basically said, and he goes, I'm going to be great now. And I go, no. He was there and his wife was there. And I said, the operation bit is pretty routine. I do so many of these. That bit's fine. You're going to have a, okay, I sound like a bit of an arse. You're going to have a brilliant ACL, right? That's what I said. But I said, how you do in a year's time depends on you. You do the rehab, you put it in. A year from now, you're playing paddle, football, 3 times a week, maybe longer, 12, 18 months, but you're 3 times a week, you're not thinking about your knee. Same surgeon, exact same operation, you don't do the rehab. A year from now, you're hobbling around saying that bastard ruined my life. Yeah. And that's a very standard spiel I have with these patients. And I go, the operation is not the difficult bit. It's what you're going to do in the gym if you're going to put it in. We've had a couple of patients who haven't put it in, and it's been difficult.
Really
and we've had many who've put it in, have done phenomenally well. Yeah. And it really comes down to the patient, their motivation, their mindset, their buy-in to rehab. And also, people need to understand that rehab is not just that one session, that 30, 60 minutes with the physio once a week. I tell the people, you've got to put it in every single day. You've got to be doing stuff in the gym.
This is the physio coach's mindset, right? This podcast is now called the Physio Coach Podcast. It's something I've been leaning towards for a long time, personally. I feel that the coaching mentality is perfect for us. I think it allows us to change lives. We're not just doing a therapy on a person, we're genuinely coaching someone towards changing their life. And as we can hear, like ACL rehab is no joke. I've done hundreds of these myself, and it's tough. The patients have to work hard. They've really got to put the effort in. And that the title of this very episode today, The Special Sauce, I'll let you kind of give us the punchline for this. So, the special sauce of ACL, treating knee injuries. So
yeah, I mean,
what did you call it?
I did a post about this, and in some ways, we spoke earlier, like before this, and I said, maybe I won't use this because I feel like it's maybe a bit, tacky to say it's grit. It's the gritty person. It's the person that's, gets up on the day they don't feel like it and carries on. It's the person who's got that within them, that perseverance, that willingness to show up even when they've had a bit of a setback, or when it's not going as quickly as everybody else, and you basically said, look, I think you should just use that line because it's true, and I believe it is. For those that haven't read it, you should go and read the book Grit. It's really good, by Angela Duckworth. It's really good. And the big tagline in that is grit is coachable. It's learnable. You can build or develop grit. And she shows how they do it in young, people that do spelling bees and all that sort of stuff. And it goes through a whole range of different athletes and all sorts. And the point is, and I realise I'm probably going off on a tangent, but the point is that I reckon we see people that have gone through struggle in some way probably do a bit better because they know struggle. They know a bit, they know hard. And I think that comes with sport. That might come with learning the violin. You might have played violin all your life and that was really tough. It could be whatever, but I do think that those that have had hard do better in hard situations. And we as coaches can help them learn that this might be their first hard. We're going to help them be better.
Yeah, I think
through this hard.
That's a real key part. We have an opportunity to help to coach these people towards being gritty, being consistent with their rehab, because that's absolutely key. Being consistent when they don't fancy it. So I think we've got a real opportunity to do that.
And I'd add to that it's funny, we as surgeons get a disproportionate say in the matter and an involvement, but we only get a snapshot of these patients every 6 weeks or 3 months after a period of time. I will probably see someone on average 5 times in the year after their operation. So my standard is 2 weeks, 6 weeks, 12 weeks, 6 months, 1 year post-surgery. Those are the 5 follow-up appointments you get. And I get a snapshot, 15 minutes, you bend your knee. Oh, that one feels good.
Oh, that's a good one.
Yeah. How's it going, right? And the fact is that, my scope for intervention is relatively limited at that stage beyond the operation. It's the people they're seeing on a weekly basis, on a fortnightly basis, who can really make an impact on that patient and really govern their outcome in a way that impact it post-op that I can't.
I think that's really powerful stuff. And the gritty part, we've now naturally moved into surgery here, I think, on the whole anyway. Let's really draw on that. So someone has now had some level of knee surgery. What does that look like on the other side of surgery for the physio? What's the physio helping them with? Any different to the prehab side of it, to the post-injury?
Yeah, I suppose there is. I mean, maybe not. If we just said on the other side of surgery for a second, because prehab's going to go to the same point if there's not surgery, but it's just goal-driven, it's task-driven, isn't it? I think good rehab is basically saying, okay, well, what is it you're looking to do with your life? What sports do you want to play, Charlie? I want to play golf and I want to run. Okay, well, that's where we're going to go. And then you go, okay, well, what do we need to do that? Okay, well, the first step is he needs to be able to swing a club. Okay, to swing a club, what does that look like? He needs to be able to do this. Okay, but to be able to do that, he needs to be able to do this. And then you just reverse engineer the process back. There is a point at the start, though, where you're just ticking off the fundamental bits. Get the muscles bigger and stronger. Get it so they can produce force quickly. Get it so they can absorb force and, control stopping, braking. Get it so they can twist and turn if they're going to go back to football. Get it so it can take rotatory forces if it's golf, as an example. Get it so it can take repetitive loading if it's running. But, it really should, good rehab really should depend on the destination, to be honest. It's just that bit in the middle where it's a bit more generic, let's say. You have to fulfill the fundamentals of getting somebody better: strength, power, speed, agility, landing. You have to do that before you can get to the bit that's maybe a bit more specific.
How much do you talk to your patients about phases? because I know the kind of the Melbourne criteria is something I used a lot. It's got very distinct phases within it. How much are you using those phases?
Yeah, I mean, I teach on our course. I don't call it phase 1 or 2 or 3 or 4 personally. We use more digestible terms. So we use able to train, learn to train, train to train, train to compete as the sort of phased process. And the reason for that is that I think, actually, James came up with these, to be honest, but they resonate with what the person is trying to do at that moment rather than giving it a number. Like initially I'm just learning to be able to go back to the gym again. My knee is learning, and then obviously training and all those things. So I don't really reference them if I'm honest. I tend to reference, I work in a corporate environment, so I like to use terminology that's familiar to them. So I say we've got some KPIs for this point of your rehab, because they understand KPIs, and you've got some HVT, some high value tasks. That just makes sense to them. That's the language they use all the time. So your KPIs are that we're going to get you back running. To do that, you need to be able to jump, hop, land, all those sorts of things. You need to be this strong. Your high value tasks are you need to go to the gym 3 or 4 times, you need to practice your plyometrics maybe twice a week, and whatever else it is that I might have given them. And I mostly I try to really focus in on what do you need to do now? Because that's most of the time when they come to see me, they want to know what the next bit looks like. They want to know where they're going, but then they need to know what to do now to get them to there. So that's how I talk to my patients. If I maybe worked with the younger athlete, the younger caseload, I wouldn't talk about KPIs and HVTs. You'd talk about focus points or targets and activities. And I try to use things like that rather than phase 1, phase 2, phase 3. Because let's be frank, if I said to you what's in phase 4 of the Melbourne protocol, it's all right, I can pull it up. But if I've got to pull it up, I've immediately lost that person. I'm lucky I do it all day. I saw 10 ACLs today. So you remember it, but it's not that helpful to them. Again, I send them an email with what we just spoke about. These are like your checklist, and these are the ways you're going to get it done. And this is your program, and this is what we're working towards. It's on the Melbourne protocol. I just prefer to do it that way.
What's some common issues that you see at this phase of this time within there?
Yeah, Kash will say this as well. Like they get different problems at different moments, right? You get the ones that can't get rid of the swelling at the start, and I think there's a range of different reasons why that is.
Are we allowed to blame the surgeon?
No, sometimes. I'm joking. No, unless look, you can't blame the surgeon for infection, but unless it's an infection that happened at the surgical moment, it's probably they're doing too much too soon. Yeah. It's typically steps. And I'm quite aggressive with telling them that they need to do as few steps as possible. I call this the Netflix and quads phase. Relax, get off of it, because every step is a leg down, it's creating some swelling if you've not got a good quad and a good functioning knee. So at that phase, it's probably the swelling that's the main problem. Then there's a little bit when they get rid of the swelling, they start to get a bit stronger, but they might not have control of their quadricep function. Those are like the ones that develop this kind of post-surgical fat paddy type impingement type symptoms, typically in your hypermobile female or male, but typically female, that might have had maybe a hamstring tendon graft that are a bit bendy and end up with that pinchy fat pad impingement type problem. That kind of lands at a slightly different moment.
And that's probably my biggest problem actually in the early acute stages.
It's the biggest one.
The swelling is actually, you're right, by offloading it, I get all my patients to buy an ice machine, some form of cryotherapy, and if there's a notable effusion at 6-10 weeks, I'll aspirate it. No injection, just take the fluid out, suck it down, and that really makes a big difference. Don't often have to do that, but the challenge for me is an anterior infrapatellar pain, which is worse on going downstairs, worse on doing an extension of some kind, and worse on forcing a straight knee into the bed to get hyperextension. So it limits extension, and that is almost always the fat pad, 99% of the time. And the biggest problem for me in the first 2-3 months post-op is fat pad related pain, post-arthroscopy, particularly post-ACL. Because you've got that fat pad full of a sponge full of nerve endings just at the front of the knee. The instruments, the camera, the shaver, the probe goes through that fat pad repeatedly. You're blowing fluid up in that part, it swells up anyway. And the hardest thing for me, and the thing I'm really anal about increasingly, is just getting on top of it early, getting them to do regular patellomobilization exercises to get that knee moving so the fat pad doesn't get sticky, to massage into that area, and to ask the physios often to try and tape it, to try and offload it in some way, to do their bits. But I'm really, really particular about the fat pad in the first. The swelling is a challenge always, but it's never that much of a problem to treat.
I think most patients underestimate how much it's going to hurt, actually. I think they tend to come out and are surprised by the pain. These days, if I see them beforehand, I'll make sure I tell them there's a good chance it's going to really be sore for a week.
So it's interesting you say that, because my experience is different. Because I see all my patients at 14 days to take the sutures out, do an x-ray. And it surprises me, and there are a proportion of pain, and I'm not going to question your experience because you've seen these. But I see them all at 14 days, and I go, are you off the painkillers? And the vast majority tell me they took painkillers for a few days only. It surprises me, but the one thing that my patients are doing is icing it with an ice machine for 30 minutes, 4 or 5 times a day. And I think that's as effective, if not more effective, than painkillers. Yeah. So maybe that's the difference.
That's why usually I'll prep them and say, do less than you think.
Yeah.
I think you've said it as well now, the Netflix and quads, I think I really like that. So they all think they're going to get back to work, they all think they're going to be commuting immediately, but they just need to take time.
It's just not helpful. I think, again, we work in London, obviously, and in this situation, I think everybody, work is important, right? Work is their life for some of these people. A bit like I said, runners, that's how they describe themselves. Some people describe themselves as a trader, and that's what's really important to them. But it's you're going to be a trader for 30 years. Your knee's with you forever. It just wants 2 to 4 weeks for it to calm down before you can start to do some stuff. Give it the 2 to 4 weeks. Yeah. Normally, they've got a job where they can work from home.
And that's really changed since COVID. I say for the vast majority of my patients now, they can just work, I say take a week off work completely and then work remotely until such time you feel comfortable to commute. Might be a month and a half, and then go in then. And that really, the ability to work remotely has made a big difference, I've noticed.
Definitely.
Once they're out of this acute phase, their knees straightening well, their quads are firing, they're walking relatively normally, hopefully normally actually by this point. What's the next phase for this person?
So I always talk to them about trying to restore muscular size, capacity, if you want to call it that. So I'm big on an example, right? So I saw someone today who was on their 3rd ACL, unfortunately. They'd injured it about 2 weeks ago. He's had a hamstring and then a quad tendon graft, not one of his patients. I said to him, your quads have got really small. It's only 2 weeks. It's not that swollen today. He was doing quite well. He wasn't unstable. I was like, did you get that back? Well, I felt like I got my strength back, but it's always been kind of this size since. And I'm not saying a smaller muscle can't be a strong muscle, but typically I'd say a bigger muscle is a stronger muscle. And I would say, we want to lay down the foundation so that you can move heavy loads. We know, especially if they're a change of direction athlete, we know to change direction takes a lot of force. So we need to set the foundations for that. So I'm looking at trying to build up the capacity, the endurance of the muscles, whilst I can't use heavy loads, and really beeline in on trying to restore muscular size, trying to get their quads to be big again, their calf. Very often, one of the things that's missed in this early mid bit is the calf. There's no reason why we can't beeline into the calf early, other than pogos, depending on how far they're in, or jumps, sorry. There's no reason why we can't sit them on a machine and just get them doing, soleus type raises or gastric raises with load if the knee's tolerating that position. So, if you want to run, you need calf function. If you want to jump and hop, you need calf function. Anybody here that's tested somebody at 6 months or something, you look at their drop jump or their hop or their land or any jumping test, they're going to be down on their calf power. Underneath power, to be powerful, you must be strong. If you look at the equation for power, there is strength. So we can start to work on these things. But let's say before strength, we probably need some size and some muscular function and capacity. You just kind of think a bit like that, almost like in a way, you're looking at that old school pyramid, right? Like sport-specific skills, range of motion, muscular size, endurance and capacity, strength, power, sport-specific movements. It's basic, but it works. It's been like that for 50, 60, 100 years for a reason.
However, unlike that pyramid, I think the phases should blend.
It's a Gantt chart. It's not a pyramid.
Yeah.
I always teach that. It's the same with the phases, right? This is why phase 1, phase 2, phase 3 is not helpful, because you might have a calf that isn't quite as good as phase 4, but you might have a quad and a hamstring that's absolutely killing it. So there might be some things where we can absolutely beeline in and really go for it, but there's going to be some things where you're in this phase. If you've ever seen if anyone's ever done a renovation, they'll see a Gantt chart. It's like your kitchen, and then your plasterer, then you've got your painting, then you've got your kitchen, then you've got this thing coming in, right?
They're all in there at once.
And they're all in, but they're never just like, the plasterer's finished now, so I'll get the painter in, and then the painter's finished now, so I'll get the kitchen in. It's like the geezer's like, sorry mate, can I just put that tap in there? Yeah, cheers. Because it just happens quicker. Yeah. That's how rehab should be.
Can I ask a question?
Yeah, of course.
One thing I'm always looking for ways for patients to get better, and the challenge in the early stages is adding size, adding strength without adding load necessarily. People can't tolerate load. One thing I've been looking into quite a bit lately is blood flow restriction therapy. It's a thing most surgeons know nothing about. I honestly didn't know much about it a year ago. I've been researching it quite a bit. I want to know what your experiences are of it in the ACL rehab, in that kind of first 3 months.
Yeah, so there's been, obviously there's been a number of studies that show that you can use it pretty early, right? So I don't think we need to worry about unless they're pregnant, which is not likely to be if they've had an ACL reconstruction or a clotting disorder. You can basically use it from day one. You might not choose to because they've got healing wounds, and I personally don't use it until at least 2 weeks, until he's seen them and said, I'm happy that the wounds are dry and such and the swelling's down, but you can use it pretty quick. My experience is that it definitely helps with pain because you can use less load. Yeah. It's very effective in your anterior knee pain, more slightly less grumpy fat pad, but more like a patellofemoral kind of anterior knee pain type situation. And it helps the patient feel what exercise should feel like again.
Yeah, they get that burn.
And that is powerful, because I very often will sit and I see lots of people at 6 weeks, 8 weeks, 10 weeks that I maybe didn't see at the start. And you're like, okay, have you felt like you've trained in this process? And they'll very often say, well, I do a bit of training. I don't get any soreness the next day in my muscles, but sometimes my knee. Yeah. I don't feel, it's not like exercise, it's just like rehab. It's like, okay, but we know if you look at bodybuilding research and muscular size stuff, it's like the pump is quite an effective barometer for whether you've got a good enough stimulus for muscular size.
And for driving hormonal growth.
Yeah, and I know you went and tried the Hydro shorts on the other day. Yeah. I'm sure probably after about 4 reps you had a pump. but
just put them on, just the straps.
With respect, you probably got that feeling relatively quickly.
Yeah.
The positive is that it doesn't drive you don't get the soreness like you get from heavy load, like the eccentric load that you get from heavy training. So you can go again.
Yeah.
So the positive is you can keep filling this box of this hypertrophic stimulus without the kind of fatigue element.
Yeah.
And in that early mid bit, being able to repeatedly train means you're going to hit the sets that you need. It means you're going to hit the difficulty that you need. So I would say I use it more than I don't use it in my cohort, because I see a lot of corporate people that may not be used to training like some that PTs or people that have been exposed to lots of training.
Yeah.
And helping them understand that, helping them get through that bit where they're learning what training feels like, I think it's really useful for that.
I must say for me, not going too far off a tangent, but a lot of my ACL reconstructions are associated with another operation. I now do quite a lot of international patients who've traveled a long way, patients who are having revision ACLs. And alongside that, there'll often be an osteotomy or a cartilage transplant or a meniscus transplant, increasingly. And they really can't take load for the first couple of months. And so for me, I'm looking for other avenues. And I must say, I'm not saying it's definitely the answer, but I'm certainly intrigued by it. And I'm looking into it more and more. And I'm finding that what I'm reading about it, what I'm experiencing about it is looking encouraging.
Yeah, the research basically says it's not better. It's not better than training without it, But it might be, like we said earlier, it might be for some the entry point.
Yeah.
And because sometimes you can't, we certainly know with all these anterior knee pains, you might not be able to get the stimulus you're after in the muscles you're after. In some people,
some of them can't tolerate a heavy leg press or a leg extension if
Yeah.
they've got that fat pad that's really irritated.
so it might give you a window, it might give you an opportunity, it might give you an entry point. And the other thing that's somewhat underused is early neuromuscular stimulation. And in the people you really don't like, you combine the two.
Okay.
And that probably is the best stimulus,
Yeah.
but
So
it's quite intolerable.
I must say, on all my operation notes, it says fine to commence EMS straight away.
Yeah.
I'm a big fan of that because swelling down is an issue at the beginning, but I say always manageable. The fat pad is an issue, but irritable. But everyone has muscle loss, muscle atrophy, and getting that back is the key to managing the load and the swelling going forwards.
Yeah, probably. The final bit is most people don't eat enough. That's probably the thing that we need to talk more about. Really, is that most people are not meeting their calorie goals or meeting their protein goals to actually sustain the training they're under.
And part of this is probably because they're not used to training, right? So they're not used to the performance end of training in the gym where they have to fuel the work they're doing.
Yeah, exactly. And you can't build a house without bricks.
And you've got to get into an anabolic phase, otherwise you're going to struggle to recover from surgery.
Exactly.
At this point, many people are starting to get their strength back. They're using the gym. Their muscles are growing. They're feeling more confident. They've got a stable-ish knee at this point, and they're starting to ask you about running. Normally about 6 weeks in, they're like, when can I run? When can I run? When can I run? And you're having to rein them in. But what's the things that you're looking out for and supporting them with when they're keen to get back to running?
Yeah, look, the first things first is you never run on a swollen knee, regardless of how strong you are.
Because?
Well, it's telling us it's not ready for more than the load you're already exposing it to.
And the other reason is because essentially fluid
Inhibition.
can soften the cartilage.
Yeah.
And I've seen cartilage crumble almost like chalk when it should be like marble. So that's another great reason not to do it.
Yeah, so that's without question.
Plus it switches off your quads,
Yeah,
all the
inhibition,
things that,
all those
the
things.
neuromuscular inhibition that it comes with it.
So it can't be swollen. You must have full extension compared to your other knee, ideally, and I'm a stickler on it. It needs to be the same as the other side. Your knee will, in my opinion, your knee will never feel like your knee until it looks and behaves like your knee did. And if your knee had 10 degrees of hyperextension, in my opinion, you should try and get that back. Because for those that are hypermobile, anybody that's got hyperextension here, if you ask them to squeeze their quad at 0 and then ask them to squeeze their quad at their full extension, I saw the guy I saw today, I said to him, does that quad, when you squeeze it, because he only had 0 and hadn't got his full extension back, does that quad, when you squeeze it as hard as you possibly can, does it feel like your other one? No. Well, that leg can't operate at the intensity that one can. Is it a surprise that one's re-injured? Probably. And then it's hard to say that's the only reason. I'm not saying it is, but it's part of it. So they must have their full extension, must have at least 120 degrees knee bending, but ideally within 10% of their other side. And normally by this point, knee flexion is not normally a problem if you've managed the swelling and the pain correctly. But at least 120, I would say, is a bare minimum. I want them to have done enough strength training so they meet their strength training target for their gender. And typically, if you reverse engineer, most men that are playing athletic sports need 3 Newton meters per kilo to return to change of direction sport. If we said that you need 70% of that, which is most of the protocols say you need to be have 70% restoration of your knee quadricep function before you return to running. Well, 70% of that is 2.1 Newton meters per kilo. So I say you need at least 2.1 Newton meters per kilo on the knee extension. Obviously, I say to them, don't worry about that. I'm going to do a test and I'll tell you if you pass it. They should have pretty close symmetry on their capacity tests. So you might do how many bridges, how many calf raises, how many single leg squats, how close are they? You want them, to be honest, at least within 15 to 20%. We know that those that have 15% difference in their quad function, when you put probes on and stuff and you video them and you slow-mo it, they still run different. The more gap you leave, the more different they run. What we see less extension moment, so less force, and we see less knee flexion. So a stiffer, less quads functioning knee is more likely to become a painful knee. So for me, it's like I need to be seeing these quite high barriers be met from quads function. And to be frank, quads function is probably the biggest indicator of successful return to running. That's the number one. We spoke about range. They need to have, ideally their hamstrings need to be functioning well, especially if they've had a hamstring graft. So hamstring, you can probably go off of the 70%, ideally age-related norm or their healthy leg before, like as close to their injury as possible, or an age-related normal value. And then you want their calf to be functioning well. Typically I'd use, we know that you need, in your soleus, you need 1.5 times body weight to do like running and change direction work. So I'll test them on a force plate, or I'll test them with a handheld or a force frame or something like that. And we just have these barometers, these metrics that we're going to run through. And I just say to them, look, this is your minimum criteria. If you don't tick those boxes, I'm not going to tell you you should be running. Because if we do, it will swell, it will get sore, and then we'll go backwards. And as soon as it swells and gets sore, you'll have to come off of what you're training, and then you will lose muscular function. And then it's just like a hamster wheel. You just go round and round and round. So whatever your criteria is, and there is no gold standard agreed running criteria, and it's important to say that. There isn't a one where you can just say, I'll just follow that. There are a number of protocols out there, but it's not like there's one that is the given. So find the one that works, that you're happy with, and be an absolute stickler to it. Because one of the biggest mistakes people make in ACL rehab is returning to running too quickly. I can say in my cohort of people, and I'd say we do this quite well, most corporate people will not run before 5 months because they just cannot tick the boxes. If you deal with a more athletic population, I know some of you guys might, people that are used to running, used to training, used to getting bigger muscles, have a body that's used to training, you might get there a bit sooner. The professionals are running much sooner than that. But they're professionals for a reason. They are, unfortunately, better athletic human beings than we are.
It's interesting hearing that because, I'm familiar with what you're saying, but it is still surprising me how many surgeons will give a time-based still in this day and age. And I find it just shocking because we know that all these factors go into it. You can't just say 3 months you're running again. But the problem is if someone says that to the patient, that really makes it a difficult conversation for them when they go back to their physio.
Yeah.
I kick back a lot on it and I'd say, look, the surgeon is the expert in surgery, but I'm the expert in rehab. And I'm happy to confidently say that to my patients. Say that sometimes they might say these things because they're focused on being the best surgeon. They're just aware of some of the rehab things that might be slightly out of date, but I'm focused on the rehab, so I keep up to date with this stuff.
We do have to accept that running is a big moment. It's a really important psychological moment. It's probably the moment that's spoken about the most. When can you return to running? When will I return to running? It's probably one of the biggest barometers about actually getting better for the patient early stages. So we can't gloss over it. We just need to set a system. And I just say to them, look, this whole process is going to be systems based. And when you tick all the boxes, I want you to run. I don't want you to think, I don't want you to run. I just want you to run when it's the right time to run. And the other thing that I try to almost like bring it back a bit is to say, you didn't come here to get back running. You came here to play football. Running is part of the journey to get back to football. So it's just another step. Yes, we need to get through the steps, but let's not put it on a pedestal. Yeah, right, we need to get running, but it's just another step. We'll do it at the right moment. Because if you run when you're ready to run, you will enjoy running. If you run when you're not ready, well, we'll go back and it'll be a horrible process because it's really frustrating.
Once someone's ready to run and they successfully manage that, what's the next step?
Yeah, well, the next step is effectively trying to make sure they're powerful. You'll have done some of that pre-running, but you need to start thinking about the activities, the motions, the movements, the forces they're going to be putting their body under to do the sport in question. I guess the learn to train is how we term it, train to train is how we term it. So you're going out there to try to get back to the pivoting if it's football, the cutting, the change in direction, the skiing if, it might be that kind of multi-directional movement around your knees as such. But the next bit is kind of getting you ready, as once you're through your running syllabus anyway, getting you ready to do the more advanced movements that are still not quite playing sport, but are going to be involved in your sport. And most people get back running, don't do enough plyometrics, high speed, high braking force, stopping, changing direction in a controlled environment and working out how good they are. Most people don't do enough of that. They go from running to training. And running as in training for their sport, sorry. Yeah. And still all they do in there is strength training, quite typically still 3 sets of 10. And we know to use those like high motor units that you're going to need to basically run as fast as you can over 10 metres, slam the brakes on, stop and go back the other way because you're a fullback at football. 3 sets of 10 on a leg press at 50%, 1 RM. That there is going to expose you big time. So you're sort of bridging those gaps now, And typically this is the bit where, I use the term leverage. And I'm not only a physio, I run a small property business too. And in property, leverage is normal. So you use other people's money to buy houses. You use systems to manage properties as an example. In physio, we all expect to know everything and do everything. Quite frankly, we don't know everything. And there's a reason why strength conditioning coaches, surgeons and such, and coaches and PTs and all that stuff, we've all got our space. And when we start to get into this power development, this speed development, this change of direction, this high force environment, I leverage James or I leverage an S&C coach. And I say, James, or any S&C coach, this chap's ready to start to work towards training, change of direction, getting on the field. Can you have a look at him or her, run them through some tests? And if you're happy to take them outdoors, once they've ticked the boxes to do that, you can do so. And you start to make a collaborative decision about how good this person is. Because I've worked with them for 6 months. I'm a bit like, I've got the rose-tinted lenses on because I really want this person to get back to football. But you might have met them for the first time and you run them through a load of tests and go, Andrew, that's good, but their braking force on whatever test or whatever is not that good, and I'm a bit worried. And that's where building a little team around you is important, because that's going to help you get through this next bit. Because most people, if they're going to re-injure, within the rehab process, are doing it after running. They're doing it in that bit where they're back on the field, or their first 100 days to 200 days of returning back to sport. Typically somewhere between 7 and 9 months. Far too soon. Getting this bit right is just as important as getting rid of the swelling and such. Maybe more important.
The tricky bit is that most people feel normal, and that's the hard bit. So this is where the grit comes back, the secret sauce again, because this person is living their life normally. They're running so they feel normal. They've been able to train a bit so they feel normal. So you have to be able to really show them that they're not, and that they're not ready yet. And this is where the technology comes in. I think my main reflection and my main learning shift a few years back was using force plates and figuring out that people needed to be working their power quicker. I was spending too long focusing on strength when their strength was actually pretty good, but they weren't powerful. They couldn't handle single leg jumps. They couldn't handle landings. Yeah. So that shifted my rehab on really significantly a few years back. And not everyone will necessarily have that tech, but there are ways of using apps in your phone and all sorts of other things. Even just looking at it, sometimes you can see the difference.
I mean, I know, when we teach on our course, we say if it looks different, it probably is different. Do you know what I mean? If they land off of a 40 centimetre box and one they land really stiff, and the other one they absorb it really nicely and they look really comfortable. On the one that was really stiff, they kind of grimace and they look a bit nervous and they didn't want to do it. Well, the tech's going to help you, but it's probably already told you it's different, right? Until it looks really normal, the tech is giving you numbers that I'm not saying you know the numbers, but you already know it's different, right? Personally, I leverage technology for all parts of this because we have it. If I didn't have it, I would focus on that to start with. And then I'd refer them to someone that did have it. And that's the other thing I think physios are bad at, with respect. I think we're just bad at saying, do you know what, I don't have an isokinetic dynamometer in clinic, so I don't. but that's the gold standard test for whether you should or shouldn't return back to sport, is £140. I know a place in London that will do it. You might need 1 or 2 of these. But if that finds a gap that we should have found, that we didn't know was there, that we then treat, and that stops you re-injuring, that's the best £140 you spent in the last 10 years. So we've got to get okay with saying we don't know everything and we don't have everything. It's not a good enough excuse to say we don't have a leg extension machine. I haven't had a leg extension for 10 years, but there's ways around it. I don't have an isokinetic dynamometer, but I send people for it. I can't, my appointments are quite short. I can't go outside with you, but I'm going to use people that will. And that's why I think a very high proportion of the people that I see get back to what they want to do. It might take them a bit longer in some environments, but and we have a very low re-injury rate. That's not to say we're amazing, but we use other people, other environments, other technology to fill the gaps. I think as physios, we just got to get comfortable doing that. Physios, coaches, SSC coaches, all of it, not just physios, sorry. I'm not just pointing holes at physios.
Yeah, I think it's important to cultivate that team very deliberately around you. I know that earlier in my career, I was very much staying in my silo, very much staying in my own world about, I don't want to lose this patient and never see them again, so I'll just keep hold of them and just try my best, and I'm really working at it. And then I worked in a genuine MDT and realised, I get it now. I figured it out. So I think the more people that can seek that out deliberately.
Yeah. We have this, it's hard not to, right? You have this like scarcity mentality. Will there be enough people to fill my diary? And then you go, Kash, how many ACLs did you do this week? And he's like, 10. How many have you done this year? 250. Okay, well, I probably only need 10 of those referrals to make me pretty busy. Okay, well, I know 10 knee surgeons in London. If they send me 5 each, well, I've probably got too much work. Then you start to relax a bit, and you've got to get comfortable with that. So I understand why we have this scarcity, and it's not just physios, it's lots of people working in healthcare. And
Surgeons have it too.
Yeah, exactly. But
A lot of surgeons are, if I don't do something to this patient, I may never see this patient again. And you were very mischievous earlier when you said, do we do too much ACL surgery? And we do. Because I think there is a scarcity mindset amongst some surgeons as well. And that's not necessarily the best thing for the patient.
Yeah, you were talking about leverage earlier as well, and that did make me think about, our sponsor is Arthrosamid for this episode, and I got involved working with Arthrosamid because of a patient who I couldn't help, and we were using leverage. We were trying BFR, we were trying Compex, we were trying all the rehab that I would have tried with a standard ACL, and he developed post-traumatic knee OA. He had very young case, and there's a team of us all scratching our heads thinking what we're going to do with this case. So he ended up going off to Denmark and having the injection before it was in the UK. And I've been tracking data the whole time and watching his numbers. And he did really well. After his Arthrosamid injection, he did really, really well. So that leverage can extend beyond our typical as well, understanding that these things exist now, understanding these injections are here to stay. And it's a difficult decision for that person. They have to really consider all the ramifications, and the surgeon should be involved. The patient needs to be aware of all the evidence attached to it. But it's another option for people. And I think it's a great thing that's hopefully kicking the total knee replacement can down the road for many people if they can choose it. So it's just another opportunity there for people.
who have you found that this injection is working best for, perhaps? I mean, I know we've got the Arthrosamid guys here, but in your case and what you've seen, because I know you've seen a few now, like you asked me earlier, what are the indications, not maybe as specifically of that, but what case do you see that does pretty well with this?
The younger person does better, but the success is definitely better in people that are below 70. So if they're a bit younger, a bit more active, probably because they can move and then rehab after the pain relief, that's probably a good sign. But also the one who really doesn't want surgery. Some people just don't want surgery. And the steroid hasn't worked, the HA hasn't worked, hyaluronic acid hasn't worked or hasn't worked long enough. And they're looking for an alternative. So I think they're the ones that I think are best suited to it.
Yeah, nice. And with the sort of rehab process, it'd probably be useful to, certainly for me as well, and maybe interesting for Kash too, is how does the rehab process go with that? I'm interested.
It's the same. It's everything you've just said, right? It's about building size, building strength, getting them back into the function they're looking to do, reverse engineering from what they're trying to achieve, including some plyometric work and power if it's relevant for the person. It's the same. It's the same as treating any knee injury. You've just got something that can help calm down an angry knee that nothing else is working for.
Yeah, nice. Have you done many of those?
No, it's not. But also, it's because I don't see much arthritis. Somehow, my patient cohort tends to be more sports injury related, 20s, 30s, 40s, occasionally 50s. So I really don't see much arthritis, particularly being in central London.
Central London, yeah.
You know, you don't see much. I think on the peripheries you do. So it's not a thing I've ever used, but people that I know and like and respect use it. Yeah.
It's an important option as well, isn't it? Because I feel like OA is like, you know, you almost get like banded with like, oh, you've got OA. It's like, oh well.
Game
Yes.
over.
Yeah, exactly. And it's like having an option, having something else that might work really well for you, especially in that, like say, the younger cohort. It's like we need things that are going to help this cohort because it is a tricky cohort. Like, you know, because it's almost like it's going to be like a lifespan type of injury. You know, it's not this kind of IT band that's eventually going to get better and go away. It's going to be a lifespan injury. So it's having these little tools that can, like say, kick the can down the road or help us manage this.
And certainly for me, with the younger patients that I've seen, I've gone more and more into knee preservation surgery. So I'm probably doing 2 or 3 meniscus transplants a month, having done none a couple of years ago, cartilage transplants. The idea of rebuilding a knee with native tissue, not with cartilage, with meniscus, not with metal or plastic. I'm doing more and more of those.
I think it's a good chance that we can kind of almost round off our main part of this episode to talk about the longevity of a knee and what are we thinking about here to help someone not just get from injury back to performance, whatever that performance might look like for them, but through to old age. How do we help them have a healthy knee into old age?
I think this goes back into that like health span type of approach. You know, like it's not about life. It's not about how long you live. It's about how long you live well. And I try to talk to them about like, actually the phrase I use is you've now married the gym. And I say this all the time. It's like, you know, you've injured your knee. If you want to keep that knee healthy and well, you've married the gym. What I really mean is exercise got you out of the sort of doldrums to back to where you are. And without it, things can easily reverse. You know, we know that, you know, within training principles, reversibility is one of those principles, right? Like the sooner you was at one point, the easier it is to go back to that point, you know? So just because you hit 12 months, if you met all your markers and you're back to sport, doesn't mean you can can the gym. You've married it, you're there now. You need to keep this knee good. If you do keep it good and you do kind of keep those boxes ticked, then you're much less likely to re-injure and you don't have to see this guy again. Because the worst case is you have a surgery. And it's for OA in general, we know, you know, the worst case is you have a surgery, you re-injure, you see this guy again. He does another surgery, you rehab, you go back to sport, you re-injure, you see this guy again. And like that is where this cascade starts to get really out of control. So for this healthy, long-lasting knee, you're going to need to keep it there. You now have an injury that needs to be managed for life. Like if you went into Liverpool as an example and you saw Van Dijk or whoever it is that might be training, or whoever, any other person that's got an injury, you know, Spurs and Bentancur, for instance, who's got an injury, I bet you they have a specific program for maintaining that person's knee or that function and some testing criteria pre-season, during the season and such that might be slightly different to the guy that's got, Harry Kane example, that's got an ankle injury that needs to be managed. That's the same for us. We have these things that we might have to keep going on because that's what's going to keep us where we want to be. And personally, that's what I talk to them about. It's important to keep the diet as good as possible. We're all going to fluctuate. You know, it's important to eat that protein, keep those calories appropriate. It's important to train regularly. Mentally, it's important to train if that's what helps you, like keep a relatively stable mental, you know, mind or such, or manage your demons, I call them for myself. You know, manage the issues that you need. Because if you can do that, you've got a much better chance. And I always use the term wiggle room. You know, if you drew a pot and you put a load of balls in it, like bingo balls, and 10 of them were red and 10 of them were white, I want to get rid of as many of those red ones as possible. If those red ones are re-injuries, if I've only got 2 of them or 1 of them, then I've got 20 balls in there still, but only 1 red one, I've got a low chance of re-injury. If I don't train, I eat badly, I sleep badly, I drink too much, I stop and I just play football, Or now I might have 15 Red Bulls in that pot. My chance of injury is much higher. So I try to create wiggle room, and this is a phrase we stole from, I think it's Matt Jordan, I think his name is. I try to create as much wiggle room with that person's knee as possible by getting rid of opportunities for problems. And the more of those boxes you can tick, the more likely you are to stay out of this guy's clinic.
And I think surgeons have a role as well, because the phrasing that we use can really impact the patient's psychology and their motivation to train, exercise. Some people say, don't run, don't do that, don't do anything. And we spoke on that podcast last time, Charlie, I talked about low tolerance, and I said, this is the envelope of function for you. Within this range, you can walk, go to the gym, cycle, swim, you can run 5K once a week, maybe twice a week. If you do more load than your knee can take, your knee will cause you pain and swelling. All you can do is dial it down, get the swelling down, take some painkillers and anti-inflammatories, ice it, and you go again. And you might be able to raise your set point slightly. And I think, and I had this consultation today with a patient, was giving them confidence that it's safe to use the knee, and you're not going to cause any lasting damage, and you're not going to do anything significant if you're sensible with it. But you've got to use it, and if you don't use it, actually, you'll end up having an intervention sooner.
Yeah, if you don't use it, you lose it. I think that's that universal training principle. Reversibility will happen. So, I think to finish us off here, what tips do you have for our audience, for our guests here today, for physios out there treating ACL knee injuries? What tips have you got that we haven't spoken about today? Some key things to take away.
I mean, we've covered a lot of them. I would say you should use testing and data to support the decisions you make throughout the process. I know we've spoken about that, but I think that's really important. I don't think you can complete this rehab, or most rehabs, even your rotator cuff tears or whatever, like you need to have these milestones. That's really, really key. Be engaged with the research, whether that be on what that criteria should be or what surgeries like the LET that we spoke about or other things. You need to. The ACL is like basically the most highly researched injury in MSK. There is constantly changes. So like the more engaged you could be, the more likely you are to stay on track and be up to date. And I think that's really, really important. And outside of those, I think be open to building a team around you that supports your client outside of just your skills. If you're left with nothing else, that third point, I think, is probably the essential one, the key one.
And I'd add to that I would involve the surgeon in that team.
Yeah, he's in the team.
So we speak almost most days, we'll get massive voice notes back and forth. And I don't even like him.
Cat names, they're mostly cat names.
and the thing is, and a lot of people don't include the surgeon in that team. And there's people here, who I've had this with, who will send me a voice note, there'll be some back and forth. And just to sound as a sounding board or just to run something by them, I think that would my leaving point would be involve people, but involve as many people appropriately as you can.
Yeah.
We started this episode with my better never ends story. We'll finish it with Andy's. We've heard Cash's before on the episode we recorded last year, so we'll finish with yours. What does better never ends mean to you?
For me, it's that evolution, and I have, as I said earlier, I don't just do physio now. I do a few things, and for me, it's that constant search for what gets me up in the morning, what drives me, finding the thing that I'm passionate about. And I've realised, and thankfully I've realised, because I was close to burnout at some point, that physio isn't the only thing that drives me. It does drive me, but it's not the only thing. And I've found this other thing that really does make me passionate. So the better never ends for me is finding the constant evolution of these things, these two things that really drive me and give me passion, and finding where that takes me and being open to that chaotic environment that we spoke about earlier, and just kind of going with things until I find perhaps whatever that end point is that I don't think exists.
Death, I think.
Yeah, yeah.
For most people.
Yeah, but just being really open to the fact that life is going to change, and hopefully for the positive throughout it. For me, that's it really.
Thank you both.
Yeah. Thanks.
Yeah. So if anyone has any questions here, we do have a microphone. I think they're going to hand round the microphone. We've got some time to answer questions. So we'd love to hear what your questions are.
So, a bit maybe of a can of worms that I'm opening up, but I'd just like to get your opinion on it. Do you think that there's a place for manual therapy in the ACL rehab journey?
Yeah. Like, whatever gets the person better, gets the person better. You know, I wiggle kneecaps, poke quads, rub calves, mobilise joints. If it gets me to the point that I want in that session, and it's valuable time spent, absolutely. You know, quite frankly, like it's just another tool in the toolbox. We don't need to, throw the baby out the bathwater. If it feels better, great. It can't be the biggest thing in the session, but bear in mind I came from a sports science background into physio, and I kind of really heavily lean on exercise. So for me, I kind of always want a part of the session to be either exercise modification or development or training or whatever. That's probably my bias, I'd say. But I absolutely believe, especially in some people, that manual therapy has helped me get past some of the problems. Whether it just be that they felt a bit better at that moment, whether it would be about them kind of taking their knee back and touching it and moving it and whatever that did made it feel better.
And I guess that's particularly more so in the early stages.
Especially in the early stages, yeah. I think that the benefit, in my opinion, weans the further you go along.
So on that, I remember hearing a podcast by, I think his name was Chad Cook, and it was many years ago, and it really helped solidify how I use manual therapy in sessions. He said that 3 to 4 sessions is normally enough to get the benefit you're looking for. If you're finding that you're doing it 5, 6, 7, 8 times, you're probably missing the point. There's probably something that you've missed that's causing all of that tension, stiffness. There's something else that they could be doing. So my spidey sense starts tingling if I'm thinking, hang on, I've done 4 sessions of this and they're still coming in with the same problem. So I'm using it as a tool to get them moving, help them feel better. And if, I'm looking for that kind of 3 or 4 for it to be enough, and then I'll move on.
Hi. If we're seeing athletes that have like the best training, the best food, and maybe luxury 10-hour sleeps, and they're getting injured, is there such a thing as injury prevention for knees? And if so, what does that look like?
Yeah, I mean, that's a big question, but like there is pretty good research, like even better research in females, that injury prevention strategies such as warm-ups like the FIFA 11 Plus, which has been rebranded to the 11 Plus, and other warm-ups that are like that. There's some for netball, some for rugby, for instance, that if you conduct them in uninjured people, you get less ACL injuries if you conduct them regularly. There's been some research to show that even if you do half of the 11 plus, the FIFA 11, even if you just do half of that in a session, that still reduces injuries by up to 60%. That's massive. So I absolutely believe that there is a mitigation strategy for as many injuries. I don't think there's anybody that would sit here, anybody that I've met that would suggest we could stop them all, of course. But I absolutely believe that we can reduce the rate of injuries that are happening by using strategies such as warm-ups that basically include some strength movements, some preparatory movements that get them ready for the sport, some pre-activation, some plyometrics, which is quite important, which seems to ready them neuromuscularly probably for the game.
That sounds a little bit like, if I've understood right, the same thing that you'll do to rehab the injury. So sort of, would you like to do similar? It's
going to be less fatiguing, less loading. It's going to be much more preparatory than kind of fatiguing, I suppose is the only word I can think of there. But yeah, it will mimic movements they have done in their rehab. You know, the other thing in football, and the contact versions of those, there is some contact. So they do like jump and bump each other, for instance. Somebody jumps, you nudge them and they land on one leg. Again, I think probably some of that is that neuromuscular readiness to that activity to happen, you know.
The evidence is overwhelming in favour of that. And there's a charity called Power Up to Play.
Yep.
If you look up Power Up to Play, they've got quite a lot of information there and warm-up drills that teams can do. And they are reducing the number of ACL injuries, notably.
The research seems to prefer the words injury risk reduction rather than prevention. And I think the prevention word sounds like there's an injury, we should have prevented it, and it's like a blame game. But it's not really that. It's like if you have enough people in the cohort, then you're reducing the risk of that cohort.
That's why I asked about it, because it's such a word that's thrown around and not, and I'm like, well, it actually works.
Yeah.
Exactly.
Yeah. Yeah, and like I say, the benefit is there's lots of versions out there for different sports. You know, I used to work in rugby. If you gave them the 11 plus, the football one, there's no way they're doing it. This is football, not interested in football. So like you have to lean into that sort of environment, right? You need to, and having these multiple options, especially in the sports that are most at risk, especially in the female cohort, I think is important. And we need to reduce the rate, especially in the female cohort.
I think there was a question. Oh, there's a few. Yeah,
No,
there you go.
it was going to add a little bit like mobilities about as well coordination. Like a lot of people who has tinnitus is more tend to have like out of balance and injure knee or ankle injury because they range of balance.
Yeah.
So maybe one point of the taking this flag is how coordination, how much coordination they have before they have the and I mean people who have tinnitus or who has like you say, everybody has different range of mobility because they use more skills like the other, so they will flag this mobility with coordination exercise.
I think your question, just because you didn't have the microphone, I'll just repeat it and you can tell me if I get it right. Yeah, it's kind of basically your point is around coordination and movement skill, right? And we didn't cover that as much within the main episode, but I think that is a really important part of someone, especially someone athletic. They need to learn that movement, that coordination, the technique of their sports, including it within these preparation, warm-up type exercises is fantastic. It's a really good opportunity.
Yeah.
Hi guys, great podcast. Charlie, Andy and Kash, I'd be interested to know from each of you what you think the role that the synovium, synovitis and effusion can play with regards to knee health or lack of.
Yeah, well, we know that repetitive or ongoing is going, that inflammatory situation within the knee, we know is going to advance that change over time. So controlling the inflammatory environment, if we just said that, whether it just be synovitis or if we just talk about just generally in that inflammatory, the more we can control that, the less likely we are to get this evolution over time. So I think it's part of that controlling the inflammatory environment. So I think it's important. But as we see, you rarely see, you do sometimes, but you rarely see that without anything else, right? Like it's typically a kind of a few things. I mean, Kash, you can probably come in on this one.
Yeah. So most knee injuries, that an acute injury, that particularly if there's any blood or bleeding into the knee, there'll be a synovitis. If there's an MCL sprain, an acute inflammatory response to that will be a synovitis. And you do see it with osteoarthritis as well. But most scans I see have a degree of synovitis on it, and it's important to get on top of it because, as we discussed earlier, it's almost like turning on a sprinkler system in the knee. If you've got a swollen knee, you're more likely to develop a Baker's cyst, to be limping, your quad's not firing, range of motion is limited, and then it has knock-on effects on upstream, on your hip and your back as well. So it's important to get on top of it. Usually, I tend to find a bit of ice, a bit of load modification, an anti-inflammatory of some kind, be it oral, be it intra-articular. Usually oral will help calm that synovitis down. It's important to do that before you can make strength gains and then progress.
Well, I don't think you can progress typically when you're in that environment because it comes with all that inhibition that we're talking about. So they're the ones that just don't go anywhere, right? Like the ones that have got those like low-grade effusions or swelling or irritations that 6 weeks down the line, you're kind of just having you're looking at the same knee basically because it's going nowhere. So pharmacology tends to be the route basically. Hopefully that answers your question.
The Aussies obviously are increasingly looking at bracing and things like this. What are your guys' thoughts on? I mean, UK health systems aren't really set up. You look in NHS, but private, you might get people that you can see very acutely after these kind of injuries. What are your thoughts on any kind of bracing, cross bracing? Otherwise, you can read it.
Yeah. I think there's a number of different bracing strategies. I know Kieran Richardson's about to release a research review that's slightly different to the cross bracing, but in terms of showing good signs of healing. Bracing is appropriate in the right person. That's the key, right? All of those studies say if you get the right person, the injury's right at the top basically, and it hasn't flipped down into the notch, and the stump hasn't died, and you can get it close enough in the right amount of time, you've got a chance that you're going to get healing. Yeah, and that spectrum of healing varies, and there's some argument about what healing means and whether it is healed and such, but let's not go into that right now. I think there's a place in the right cohort, and we're basically, at this point, I think we're trying to find exactly what the right cohort is. I'm going to try and find how long you need to brace them for. And I would almost flip that. I think if we could see these people acutely in the NHS is the place that would be the best place for if we saw these people. Because you can't get an MRI for 12 months or whatever it is. You can't see a physio for 6 weeks. And when you do see them, you see them for 30 minutes every 6 weeks. And normally they're a band 5, no offence to band 5s, and they've seen 2 ACLs in their life. I think if we could get that into the NHS in the right environment with the right structure behind it, I actually think it would be really positive. It will also be really positive in the private environment, but like Kash will say, how acutely do you typically see the knee? It might not be as acute as it needs to be sometimes. Because sometimes they've walked around in it for a bit, they've got the swelling down, it hasn't given way for a little while, and then you're past the 2-3 week mark, and then all of a sudden that brace doesn't work as well. So even though we see them acutely, we don't always see them day 2.
So it's a really poison question you've asked me there, because so genuinely, I'm really happy not to operate on people, and I'm be quite happy to do less ACLs. I've got enough. And so it's all awkward when a surgeon gets asked that question, because we have lots of concerns about it, basically. Of course, there's the logistical, practical element, have your knee locked at 90 degrees for a couple of months, 3 months, and there's still a quite significant failure rate that goes to surgery. The other challenge is that an MRI scan is not a very good assessment of healing. It is very much a dynamic test, examination, be it a Lachman test and a pivot shift test that gives you an idea of how actually... See, the issue is when you've got your ACL like that on the MRI scan, and when you rip it, it goes like that and it changes colour. And then afterwards, it can look like that again, and the fibres can be sat there. They can still be fully torn, and the minute someone does a Lachman test or an anterior draw, those fibres go like that. And that ACL is not functional at all, but on an MRI, lying flat on your back with your leg out straight in the scanner, it looks like it's healed. And this is genuinely not surgeons being protected. Maybe for some it might be, but for the vast majority, it's not being protective of their practice or of their, of their throughput. I think that I'm all for things that will stop people having surgery. I'd like to go to injury reduction, things like, like the power up to play. And we are supporting that in a major way. But I'm not sure that bracing is as effective as people think that it is. And I've got huge doubts about it, and I'm waiting for more evidence.
It's young. Basically, I think the pragmatic clinician should still be saying it's promising, but it's still a bit young to just go full bore into, I think. I'm not saying I'm right, but that's I think that's.
And the irony from a surgical point of view is that if you've got someone who meets a scenario that it's a femoral avulsion pull-off, that it's acute, the knee's not swollen, that they've got a decent range of bend. For me personally now, I'd actually want to do an ACL repair, which is the thing we've not done for 30 years. That is where you do an arthroscopy, just 2 small incisions, and you stitch it back to the wall. You're not taking a graft, you're not taking a donor, it's quite a simple thing, and the recovery is actually pretty quick. And that's the one time I'd think about ACL repair.
Yeah, and they would normally do pretty well, to be fair.
I'm really impressed with the ones that I've done and I've seen, and the challenge is you have to find someone who's got a femoral avulsion pull-off, which is which the majority is torn in the middle, straight through. They're not going to have too much swelling, a full range of motion, and you've got to do it within 50 days. The evidence. I can do that privately, but there's not many people that meet that criteria.
I was just going to say that's really helpful and interesting to hear. I know it would be a very difficult thing from like an NHS point of view, just judging by how poorly Achilles ruptures are managed, for example. But I'm interested to see as well.
What I would say with that, I'm not beating up on the NHS. I've worked in it for a long time, but not all of that is logistics. Some of that is skill. And I mean that kindly. Do they have the time to see, or do they have the opportunity to see the volume of the same thing, to develop the skill with that thing? So I see hundreds of ACLs a year. So I would say I'm pretty good at picking them up, pretty good at managing them, pretty good at recognising deviations. I see 4 to 10 Achilles ruptures a year, which is probably 9 more than that NHS physio that just got that Achilles rupture. And that could be a problem. So sometimes I think it's logistics and sometimes I think it's skill. And I mean that really kindly. That's not to beat anyone up, but we've got to stop saying, oh, the system doesn't work. Yeah, sometimes the system doesn't work, but sometimes we're just not good at operating within the system, you know? That might be unfair, but.
So I just wanted to kind of add in on nicely, to give some background. I kind of want to go back to, if possible, kind of what we were saying about the open chain movements we were saying at the beginning. To give some kind of context to my question is, I'm a new grad, walked in straight into a band 5 MSK job, and I'm kind of, those limitations you're saying, I'm kind of already seeing.
You're feeling it, yeah.
I kind of, where I want to go with this kind of limitation per se is looking at those open chain movements. I probably see 1 new patient a week post ACL. I'm lucky enough that I don't put them straight into an exercise class, like I get to rehab them myself. But at the same time, I see the same consultant. All of my patients are seeing from the same consultant, and on my discharge summary will always be no open chain kinetic for 6 months. On every single patient I see, it's always that. So I kind of want to see what you kind of see in terms of the criteria of when you would want to progress onto those open chain movements, given that every patient I'm getting is 6 months, no, regardless of whether.
Way before 6 months. Way before 6 months. And by the way, I hear that on my course from at least 3. Actually, I did a course in Essex, which is where I live, and there were 28, 26 people there, and they were like, categorically, we are not allowed to do open chain knee extensions with our patients because it puts strain on the graft. So I said, okay, ask the surgeon if you're allowed to stand your patient up against the wall, prop their foot up, and do a slow single leg squat down with their back against the wall, and then stand back up. And they all say, oh yeah, that'll be fine. Okay, well, from a vector perspective, from a biomechanics perspective, that is putting exactly the same stress and force on that knee as the knee extension machine would. So what's different? And by the way, that's quite an abrasive way to approach that with a consultant. I'm not necessarily suggesting that, but what I mean is, what we need to be challenging is what is the reason for that? The research is overwhelming. Okay, well, this is this study that shows recently that there's less laxity. This is this study that shows this. Unless you can develop a rapport and a relationship so that that surgeon trusts you, why would they change their mind? Do you see what I mean? Because if they've had patients that have done open chain knee extensions and they've had problems, well, it's a self-fulfilling prophecy, isn't it? My patient had problems, they wasn't doing knee extensions, that person did, that's the problem, that's why we don't do it. So you have to develop rapport. Like, for instance, I see quite a lot of meniscal repairs with Kash, and when we started, we had quite open conversations about whether he would consider not bracing them. And now, typically, unless there's a reason, when he sends them to me, a lot of them come without a brace.
I don't brace them at all.
Because we decided that the risk versus the risk of reducing their function, versus the risk of them re-injuring it wasn't worth it. You know, like the limitation of the brace wasn't worth the security for the fall down the stairs. Because if they fall down the stairs, they're going to fall down the stairs, as an example. And that took time. You know, obviously he drove that. It's his protocol at the end of the day. It's his patient. But those discussions are how you build towards something that reflects what's current. And without that open dialogue, nothing changes.
So I put it to you that 99.9% of surgeons would never know if their patient did an open chain exercise or a closed chain. Right?
Probably don't know what open chain is.
Yeah.
I was going to say this.
Alexa. And also the thing is that if it's someone's standard procedure for 6 months, that is something that is from 10, 20 plus years ago. Honestly, I've never talked or specified about open chain versus closed chain. I've never mentioned it. I've never said, don't do it. I'm not the expert in that. And I'm very comfortable. I don't have any loose ACL grafts, so whatever they're doing is fine. And it's not because I don't care, but it's because it's not my area of expertise. So I've got to trust the people who are the experts in doing it. In your situation, I'd suggest that do check the literature and you have a conversation with the surgeon. And I think it's totally fine. You can do it in a non-challenging way.
Yeah, it doesn't have to be challenging.
They just haven't been, I bet that they've just never really considered it. It was just a thing. Oh, I worry that might stretch it out, but it's not. I don't have loose ACL grafts.
Or just nobody has ever said, I'm really interested why that's on your protocol. I'd be really interested to understand what your perspective is about it, because I've got my own, and I wondered if we could have a discussion about it.
I bet it's a historical thing that's been cut and pasted forever.
That's what I was kind of going to say. I was thinking that the referral that I get is the same whether it's a 21-year-old male or a 65-year-old female, for example.
Yeah.
Of course.
So in that, even in my own situation, I back in August had ankle oral surgery, and even though my plan with the surgeon was really great, of actually, rather than a normal weight bearing 6 weeks, 2 weeks normal weight bearing coming out of the cast, and then kind of mobilising as I'm able to after that. But my discharge summary still says normal weight bearing for 6 weeks, regardless of the conversations that I had with the consultant. So when I came to see the physio that I saw, kind of for my recovery, they were like, oh my goodness, why are you walking? It says on here that you should be walking for 6 weeks. Because in that kind of NHS position, if I even dared to open chain before 6 months, I'm being disciplined. Because in terms of senior, that's what you're trying to do, is you have to follow exactly what it says on that consultant.
Yeah, no, I get that. And look, I have this conversation on every single course I teach. There's no straight answer. I'd probably give a slightly different answer to everyone about how they approach it. I think the worst thing to do is to not approach it.
And also, just from a technical point of view, depending what graft you use, it would be different. If you've got a patella tendon graft and you've got 2 screws in there with a righteous fixation, it cranks, it creaks as you put it in. That's rock solid. You can go early on that. And so there is more nuance to it. As you said, you're 2165, the graft will come into it as well. So I think there's no harm in having that conversation.
Yeah, exactly.
But have the information with you in advance.
Yeah. Go prepared. It's like going for an interview at the end of the day. Do you know what I mean? You're good because they're going to challenge you back. Rightly so.
Thanks everyone. Thanks for coming.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health and wellness services in central London. We really believe that we can help people feel better and live better. You can book in for face-to-face services at any of our 3 London clinics. We have one in Marylebone, one in Soho and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com.